It's 9 o'clock, so I think doctor, while people are still slowly joining in, I think we will start first. So very good morning to Dr. Teoh and everyone joining us today. Thank you for joining us on a Saturday night, and thank you very much, Dr. Teoh, for your precious weekend time with us. So my name is Yong Long. I'm from stage 3.2, and together with me is Lee from stage 3.1. We will be moderating today's session. So today we are very fortunate to have Dr. Teoh Li Ying with us for this session. Dr. Teoh is an NSR certified breast and endocrine surgeon and a consultant general and breast surgeon in UMMC. She actually needs no further introduction as doctor is very well known among us for being very kind and very good teacher. So before we begin, does doctor have anything to say?
Thank you for your kind words and good evening to everyone. So I just want to find out whether all 3.1, 3.2, or we do have 3.3 students as well.
Yeah,
for
doctor,
tonight.
we do have 3.3 students.
Okay, so
Yeah.
I think first of all, thank you very much to Ziyi for contacting me, and also Yonglong for all this teaching and moderating this session as well. So I think you have cases that you want to share, and probably we'll just go ahead with the discussion. And in between, any questions that any one of you would like to ask, maybe you can just post the question in the chat box.
Yeah.
Okay. All right.
Okay.
So the discussion will range probably from a very basic discussion to probably some more advanced, slightly more on the advanced side, including the management for the benefit of the senior. Okay. Right.
Okay. Right.
Okay.
So we'll be presenting two interesting cases on neck masses for today, and hopefully we'll be able to stimulate some fruitful discussion. We really hope everyone can participate in the discussion. You might either type in the chat box, or if you don't have access to a chat box, there's another Q&A box where you can type in, or else you can raise your hand, unmute yourself, and participate actively, or you want to try ask questions along the way. Okay, so we shall start with the first case. So this first case is Mr. IK, a 31-year-old Malay gentleman. We saw this case in ENT ward. And he presented with a 3-year history of swelling over the anterolateral aspect of the neck. So probably, doctor, before we proceed further in the case history, can we discuss a little bit like when we see this chief complaint, what are the things that should go through our mind when we are taking the history?
Okay, so you should know that this is you're dealing with the anterior neck mass, right? So the common neck mass you commonly seen at the anterior aspect would be your thyroid. Okay, so unless it's proven otherwise, most of the neck masses that you see in the midline would be your thyroid mass. Okay, the goiter. Other than that, things like maybe a thyroglossal cyst, all right, or dermoid cyst, all these are possible. And then you do have those benign ones like lipoma as well, but it's a bit rare, okay? So when you go slightly to the lateral, you have to think of lymph nodes, okay? It doesn't include, like in this case, it's still part of the anterior, right?
Yeah.
So then you have to think of other things like even bronchial cyst as well, okay? Where when you actually palpated, it's more to lateral, okay, and posterior. Okay, all right. I think you would present some history first so that okay.
Okay. So I adopted this slide from the browse. And so for the history for this patient, he was previously well until January 2020 when he first noticed a mass over the anterior neck of about 20-cent coin size. It was a painless mass, immobile, no overlying skin changes, no sinuses or discharge, not increasing in size over time. There were no compressive symptoms like dysphagia, shortness of breath, hoarseness, or choking sensation. No infective symptoms like cough, sore throat, or rashes. No TB symptoms like night sweats, fever, prolonged cough, or any TB contacts. No constitutional symptoms like loss of weight, loss of appetite. No other ENT symptoms like nasal obstruction, epistaxis, ear discharge, or tinnitus. No hypothyroidism at that time. He sought medical attention at the Clinic Kesihatan but was reassured and no further investigations were done. He was subsequently well with no increasing in size of the mass until May 2023, when he presented to Columbia Asia Setapak for bilateral lower limb swelling and had an angiogram, where he desaturated during the procedure. The neck swelling was noted at that time and was referred for further management. Since then, he then started to notice the mass to be gradually enlarging over the past 2 months. But otherwise, there were no other new onset swelling elsewhere and no other previously mentioned symptoms like compressive symptoms or infective symptoms lah. So this is in terms of systemic review, there are no other significant systems of note. Doctor, before we proceed to the past medical history, do you have anything to comment on the HOPI?
I think, yeah, maybe you just go back to the chief complaint slides, the first one.
Okay.
So I think it's good that you have all the differential in mind when you actually clot the patient. Okay, so not this one, no, the one on the history of presenting illness.
Right.
About the patient. Yep. Okay, that's the one. Okay, so number one you need to know is the duration of time, right? So whether is it something more acute or is it something chronic but it's getting worse recently. Okay, the next thing, what you have mentioned is all correct lah. What are the compressive symptoms, any compressive obstructive symptoms, and whether it's related to infection or is it malignancy. So like I always told my group of students, you always need to have a differential of one side is a benign and the other side is a malignant, depending on how your history goes, okay? So if the patient knows himself that it's a cancer, then patient declare to you it's a cancer, don't push away the benign causes, even though you know the diagnosis definitely is a malignant one. So you still need to include all the other non-malignant reasons, okay? So either benign lump or an infection. So just want to ask you back again, why do you actually ask on the sinus and the discharges? Anything that you have in mind?
I was thinking about metastatic, let's say NPC that can metastatic to the neck and cause neck lymph nodes.
Okay, so you're worried of probably some sort of head and neck tumor, like laryngeal cancers or NPCs. Okay. So that's why I'm a bit curious, unless you think about TB with chronic fistula because of the cold abscess, that's the other thing that you probably want to keep in mind. Okay, maybe for the sake of your colleague, you want to just flip back one slide to see all the differentials that you probably have in mind already. Okay, all right. So don't forget, I think I just recently taught the group about the other thing about cancer that you can always give differential will be the lymphoma type, okay? Lymphoma or sarcoma. So you need to include your B symptoms as well when you talk about malignancy. All right, let's go ahead first. Right, next slide. Okay, all right.
Okay. So for past medical history, he has underlying newly diagnosed hypertension, type 2 diabetes mellitus, and dyslipidemia in May 2023 under Columbia Asia Setapak cardiology follow-up. He did not do any home monitoring. The medications include empagliflozin, clopidogrel, cardiprine, bisoprolol, atorvastatin, perindopril indapamide, and vildagliptin metformin. He claimed to be compliant to the medications. He also had an ischemic heart disease newly diagnosed in May 2023, also under Columbia Asia Setapak. He had done PCI to the left anterior descending artery, and currently he's on DAPT, the aspirin and clopidogrel. He also has a OSA with a stop bank score of 6, including snoring, daytime sleepiness, hypertension, BMI, neck circumference, and being a male. He had a sleep study, a polysomnography done, and he did not have the result, but we get it from EMR. The AHI was 88 with lowest SpO2 of 40%. So this was the past medical history for this patient. Doctor, do you have anything to comment on before we proceed?
It's okay, you complete first, and then we will see. Okay, yeah.
Other histories for family histories, the father and mother has diabetes mellitus and hypertension. There were no family history of malignancies, no family history of thyroid diseases. For social history, he was a smoker of 15 pack years. He started smoking when he was 16 years old, stopped 3 months ago. He did not consume any alcohol. He was married, staying with his wife currently. He currently worked night shift as a contractor manager. There's no history of radiation exposure. So I think that's it for the history.
Okay, all right. Let's go back a few more slides before this. I think there's one more slide just right before this past medical history. No. I think you presented something about patient develop symptoms. Yeah.
Yeah.
Okay, so maybe I should probably ask the floor as well. So why do you think that patient has these symptoms of desaturated during that procedure? So despite patient doesn't have any symptoms when you ask the patient about compression, right? So
Yeah.
anyone explain?
You can type in the chat box, or if you don't
Yeah.
have access to the chat box, can type in the Q&A box as well.
So there's something that is enlarging recently, right? Okay, so what are the things that you would want to consider when a mass which has been there for since 3 years ago, right? Before that,
Yeah.
2020,
Yeah.
and then suddenly within the past 2 months has increased in size. So what can contribute to the increasing in size of the mass? Any idea? Right? Anyone can answer? All right. So possibly you have to think of malignancy as one of the reason. Okay, that suddenly part of that malignant nodule has actually increased in size. The other thing is that you need to see whether there's any bleeding into the cyst. For example, any it can be benign cyst. Even your thyroglossal cyst can also bleed. Whether there's any trauma or any recent, intervention done over that site, or in this case, even worse, patient is on dual antiplatelet, right? So you just need to rule out any spontaneous bleeding also, okay? But other than that, unless there's a acute trauma or any injury to that gland, then it explains why it suddenly became enlarged lah. All right. So no one answer me yet. Huh? I'm answering myself. Okay. So normally, when would patient actually feel the compressive symptoms? When it's enlarging in front, where patient can see, or it's actually somewhere behind?
When it enlarges posteriorly, it compresses on the trachea and esophagus.
Esophagus. Okay, so always sometimes if patient has compressive symptoms but you don't really notice a very huge goiter or anterior neck mass, you will have to consider the extension of the retropharyngeal or retroesophageal area that compresses on both of these structures. Okay, right. So especially when patient lie down, okay, the mass is actually compressing even worse. So this happened during that procedure where patient had to lie down, right? Okay, yeah. Right. And worse if you ask the patient to lift up their arm. So what sign is that? No one wants to answer. Pemberton. Okay.
Pemberton.
It's actually quite a cruel thing to do lah when patient already has compressive symptoms and yet you ask the patient to do Pemberton sign. Like, okay. All right. So now move on to your past medical history. I think it's a complete one, but it's very important for you to know that all these medications, sometimes you may need to adjust it, okay? You probably need to withhold it before you proceed to any other procedures that you want to do, okay? Next. Dual antiplatelet. And you know this patient suddenly has something which is quite life-threatening recently, okay? The ischemic heart disease, right? And he seems to be quite a patient with a high risk in general anesthesia, right? Okay, next one. Okay, I think the other thing you need to actually classify are your risk factors, right? So the risk factors you have listed here includes the malignancy in the family, right? and also the radiation exposure down there. Probably you want to know about previous radiation for other sort of cancer, especially head and neck. So to be more specific lah. So are you talking about radiation exposure place, or is it because of previous radiation for some other head and neck surgery, or even sometimes you know, when we cover our breast, we even cover that supraclavicular region. It's also actually exposing the neck region as well. So okay, other sort of cancer, sometimes you need to actually highlight as well. So in this patient, definitely you won't be able to know, like, because there's no malignancy, right? But there are also some other relevant cancers, right? For example, your breast cancer, any lymphoma, okay, even colon cancer, yep, all the those related to the MEN syndrome, all the cancers, you should actually emphasize also. Okay, not only thyroid cancers. Okay, right.
Doctor, before we
Next.
move on, I have a question about the history. Let's say in an exam, you get a case, a patient who was electively admitted for let's say an operation. They had done several investigation and workup. Should we mention that in our presentation of the history?
Yes, yes. So it's not a fresh case of that presentation anymore. Even though your chief complaint would still be the same complaint. Okay, let's say this patient comes in with the anterior neck mass, but it happens that probably 1 year ago. Okay, so in between that 1 year, many investigation and probably some sort of therapy has been done for the patient. You should still say that patient's chief complaint is anterior neck mass for past 1 year. All right, and then you start to talk about your history of presenting illness, including all the medical therapy or surgical investigation that has been done. Okay, like I say again, for the junior people, try not to get the answer from the patient. Don't make it too obvious, okay? The way you question the patient, be smart, okay? So you want to know about the treatment is fine, but you make it somewhat intelligent. Like, okay, you don't ask about suddenly, you know, have you done the surgery already when you know the mass is still there? You know, ask things like, okay, have you done the CT scan? You know, or if yes, do you are you informed about the result, or do you know about the result? Then it's fine. Don't ask what did doctor do for you? What did the doctor tell you? That is not so good. Right? Okay.
Okay. Right.
Any other questions?
Okay, if no other questions, we'll move on to the physical examination findings. Okay, so on general examination, the patient is alert, not in distress, not attached to medical equipment. Patient has a large body habitus with a thick neck, no stridor or hoarseness heard. On peripheries examination, there were no excessive sweating on the palm, normal warmth, no palmar erythema or palmar pallor, no thyroid acropathy or onycholysis. Pulse rate is about 72 beats per minute, good volume, regular rhythm. There were no fine tremors. On examination of the eye, there are no chemosis, no proptosis or thyroid stare, no ophthalmoplegia, no lead lag. The reflexes were normal, no proximal myopathy, no pretibial myxedema. On examination of the neck, there were multiple masses seen over the left anterior triangle of the neck, largest measuring about 2 by 2 centimeters. There were no overlying skin changes, redness, sinus discharge, ulceration, or punctum. The masses are ill-defined, non-tender, no increase in warmth, lobulated surface, firm in consistency, non-pulsatile, non-fluctuant, non-transilluminating, mobile vertically and horizontally, not attached to the skin, does not move on swallowing and tongue protrusion. There were no submental, submandibular, auricular, occipital, supraclavicular, or axillary lymph nodes palpable. The trachea is central, no retrosternal downers, no bruit heard. Okay, so doctor, regarding the neck examination, do you have any comments?
Okay, so when you approach a patient with a neck mass, it's best to examine the patient in a seated position. Okay, so which means you get a chair, all right, with a cup of water and probably all your apparatus ready, your paper and your tendon hammer, your stethoscope, everything with you. Okay, so you either approach at what you do. It means you do all the thyroid function status first, okay, or you go to the neck first. It's up to you. All right, so general examination comes in first, and then you can proceed to complete all the peripheries. Then you go to the neck, or you do the general, go to the neck, and then do the rest of the peripheries. Now, like I emphasized to my group again, sometimes when you complete your examination, you start off with doing the peripheries, but yet the huge mass is staring at you, and it's already time up already. So this out a lot of things about the neck lump, which is your crucial part of your examination. So what I propose is that sometimes it's better for you after a general inspection, go straight to the neck first, and then you said you would like to continue with the peripheries later on. Okay, even if let's say that your examiner asks you, I said, are you not going to check the peripheries? You said, yes, I would like to check for the thyroid function status later. Okay, so then you do all your neck examination. Okay, so saying that, maybe we just look at the neck examination first.
Okay.
Okay, so when you're in front of the patient, the first thing you look at the patient first, right? So you look at the patient's body habitus. Is he very thin, like cachexia, you know? Does he appears very agitated, fidgety, anxious, nervous, okay? Or appears calm, or even appears lethargic, yeah? Okay, so sort of I give you an idea that you're looking at the thyroid status as well. Okay, then of course you mentioned about very clear-cut hoarseness of voice when you spoke to the patient earlier from the history taking, or any obvious stridor. So looking at the neck, first thing you look at the neck. How big is it? Where is the extent? Like you said, if you can actually identify anterior triangle, then it's good. But sometimes it crosses over several triangles of the neck. So if it's more to anterior, just say anterior. It's more to the right, more than the left, or symmetry, you can mention that as well, okay? Or it's a diffuse kind of swelling. For yours, it sounds like it's an irregular kind of mass, right? Because you say it's multiple incisors, okay? Maybe you want to emphasize which mass over which side appears to be larger than the others. I don't know, because you mentioned there's multiple masses, right? Okay, so where is that largest one? Maybe it's more lateral, or is it in the middle?
More
All right.
lateral.
Okay, all right. So good that you mentioned about the skin changes. You look also at the veins, okay? See whether there's any dilated veins around that masses, okay? Whether there's any surgical scar. Did you mention that? Okay, yeah, I think you can mention about surgical scars. Look at the lateral as well as just pull down slightly. Make sure that all these buttons, at least you open the first two buttons, okay, of the shirt. All right. Okay, ill-defined, yes, okay, and whether it crosses your sternocleidomastoid. I think if you, wait, let me see. This is include, have you finished on all the auscultation and the trachea? Okay, this slide,
Yeah.
Okay, so you need to actually identify whether the neck crosses the sternocleidomastoid or not. So when you examine from the front, once you complete all that, you go to the back. All right. So in the front, you ask the patient to. That one, I think all of us know that you ask the patient to keep the fluid inside the mouth a little bit and then swallow and see whether it moves up with deglutition or upon tongue protrusion. Open the mouth first before you stick the tongue out. Okay, then you go back to the back of the patient to repeat the same maneuver again. Okay, and then you go to your lobulated surface, whether it's firm or is it hard, or is it apparently soft or cystic or fluctuant like. Okay, so only if it's fluctuant, then you probably want to add on your trans illumination, or else I think you don't really need to do for all masses. Okay, all right. Non-pulsatile, okay. Mobile, okay. Just want to ask you, how do you check for mobility horizontally?
Move horizontally.
Neck is not like breast, you know. It doesn't up unless you're talking about lipoma, lipoma, or even dermoid cyst. It's not going to be very mobile, especially horizontally. So particularly, I assume that you check when patient swallow, right? So then it moves up, okay, upon swallowing. Okay, all right. That's how you check for the mobility.
So doctor, we don't need to manually move the mass to check for mobility.
Yeah, I think it's possible for neck, okay? So you don't comment on the horizontal mobility, okay? And attaching to the skin, fine, all right. Okay, so you know how to check for whether the mass actually crosses over sternocleidomastoid, right? So you ask the patient to actually push against your hand while you check this sternocleidomastoid, the mass over this side, and then you do the same thing vice versa on the other side. Okay, all right. So then while you are still behind, next slide, check your lymph nodes first, okay, before you come in front. Check all the lymph nodes, then you come in front and do your trachea, and then you do your retrosternal extension. Okay, you can do it midline, or some books do it like bilaterally. Okay, right. I think that's fine. No one's going to penalize you for that, right? And then listen to the brewery. Okay. Examination. Yes, you say that you want to complete by. If you think it's relevant to ENT, then you want to check the ENT, or else cardiovascular. Abdomen, why?
Because I was thinking if it is a lymphoma, we might miss a hepatosplenomegaly in the abdomen, or large
It's relevant.
lymphoma mass in the abdomen.
So I think not all patients you can commit to say you want to end with abdomen examination. I think it's more specific to case by case. Okay. So if you find a lot of other lymph nodes, okay, then you have a bit suspicion of lymphoma, then you want to check for other organs like other lymph nodes besides the abdomen. All right. But you probably want to say that you want to check for your thyroid function status, right? Okay, so go back to your general examination peripheries. So now you finish your neck already, you come to the periphery, you check as usual your fingers, being okay, sweaty palm or not, pulses, all right, okay, and then tremors, put your paper there, okay, neck, look from front, look from above, okay, at the back, okay, so you can complete the one in front first by checking the movement of the eyes, do the lid leg, okay, and then only you look behind before you complete the rest of the examination, okay. All right, so reflexes, you choose one, we do lah, okay. Some students, they do knee jerk, and then your what do you call this, what do you call this, apa tu? Your, no, your brachial, your tendon, what do you call it? Elbow jerk, elbow, right? Yeah, so you choose either one will do lah, which is more comfortable. So if you're looking at lower limb straight away, when you look at pretibial myxedema for any proximal myopathy, then probably you do a knee jerk straight away. If you want, you just do once here and then check for the proximal myopathy over the upper limb. Don't have to do both lah. Okay, I think some students wasted a bit time. You do both this one and also for the lower limb. Okay, all right. Okay, I think generally the physical examination needs to be smooth lah, because it takes quite a long time lah. Okay, all right.
Yeah.
Okay, anything else on the physical examination?
Noted.
Okay.
Let's say the scenario I mentioned just now. Let's say it's a suspicion of a lymphoma in a time constraint. If we miss the abdomen examination, and let's say there's a mass or there's something there, would we should that be a priority during the exam when it's a time constraint there?
No, when it's time constraint, you just mention verbally. It's better than not saying it out lah, okay? But sometimes you are still not sure whether is it a thyroid cancer that mets to the lymph nodes, or is it really lymphoma lah. So I think the examiner will not penalize you. But if in modified long, you do have some time left, you would actually proceed, or maybe the examiner will be kind enough to just give you a hint that, would you like to check other system? Then give you a hint that, okay, if I say cardiovascular is not complete yet, then probably it's something to do with abdomen, then you probably want to add on lah, okay? But that one, I think if you have, from the history, you think that is clearly you will want to complete. Even though you have no time, you just say that you would like to just do a complete abdomen examination to look for hepatosplenomegaly. Straight away, you tell them what you want to look for.
I see. Okay.
Because about 40 minutes for everything, right? Am I right? 40 or 45, modified, no?
I think it's about 40.
40, right, I think. So best to complete all your examination, all your clocking within 20, 25 minutes. So you give a bit time for the discussion, okay? Don't go up to 30 minutes to do all the examination. Then marks for your subsequent discussion will be lesser. Okay, any other questions? If not, then we move on. Now, Now, in your mind, what do you all think the current diagnosis is for this patient? So it's a young man, right? Maybe Yong Long, you want to just summarize first for that?
So this is a 31-year-old Malay gentleman presented with a 3 years history of swelling over the anterior aspect of the neck. There were no other changes and no other symptoms, and there is a sudden increase in the size of the swelling for the past 3 months. He has underlying medical history of hypertension, type 2 diabetes mellitus, dyslipidemia, ischemic heart disease, and OSA. Otherwise, no significant family history, and no significant risk factors for thyroid malignancies or other malignancies.
Okay. So examination-wise, Marie?
On examination, the patient is clinically euthyroid with anterior neck, multiple masses over the anterior triangle of the neck, with lobulated surface, firm in consistency, and largest measuring 2 by 2 centimeter.
Okay. Anyone has any provisional diagnosis? So you have to think outside the box a bit, okay? So we are looking mainly into sometimes thyroid only, okay? But I think Yong Long mentioned it does not move with decutation, right? Or even tongue protrusion, am I? Yeah, it doesn't. So it's something which is quite fixed there. But it looks like the lymph nodes are all not palpable, right? So what could it be? All right. So the other things that you need to consider are other malignancies, all right? Probably your salivary gland malignancies, right? Or even your sternocleidomastoid tumor, even pharyngeal pouch, which is not a cancer, needs to be in part of your discussion if you think it's more lateral. You know what's pharyngeal pouch, right? You know?
Diverticulum.
Okay, so how does they present with? Does it persistently there, or sometimes it may disappear?
It may disappear and may be compressible.
Maybe compressible, and usually patient will have sort of like halitosis, right? Okay, so this one looks like something which is quite fixed there, all right? But this patient doesn't look like he's having any infection, right? So what do you all think? Can you all type in the chat box of what you think is the likelihood of the diagnosis? It's okay lah. This is not an exam lah. Okay, if you are wrong, it's I also don't know the answer yet. Okay, anyone? Just type in. You don't have to answer. You just type in the Q&A chat box. I can see Frederick's earlier message, so I think the rest can also type.
Yeah, you all can try to type in the chat box or Q&A box on what
Next
you
time,
think.
you should give a few options, and then you let them click.
I think we can consider that. Probably
Like a
more
vote,
people
like a
participate.
yes. Okay, some more. Any more? Cannot be one only, right? And knowing that this is a male patient, smoking also.
Smoker.
Smoker also. Only one Okay.
Scleromastoid lump, probably malignant.
Mm-hmm. We don't have a voting one, or else at least we ask for how many hands says malignant, how many benign, Okay lah. If you all don't know what to say, just put there benign or malignant first. Right? There's no point we keep on feeding you only, right? I mean, it's nicer to have two. Because it's like Yong Long and me talking to each other. Okay, then we move on to the next slide already. Okay, so 1, 2, 3, 4. At least 4 out of 5 says that it's malignant, Yong Long, you agree?
Yeah, I do agree because of the sudden increase in size.
A bit sinister, right? Okay.
Yeah.
All right. So maybe you want to tell them, but you want to go first or what? Okay.
So my differential diagnosis at this point in time was a metastatic lymphadenopathy It can either be from a head and neck cancers, like NPCs, or thyroid cancers, or oral cancers, or even a lung cancer, given that he's a smoker. Other differential diagnosis I can think of could probably be a lymphoma, could be an infective lymphadenopathy, especially a TB lymphadenitis, branchial cleft cyst, but 31 years old might be a little bit uncommon at this age group. Another differential is carotid body tumor, but carotid body tumor tend to be pulsatile, which is not seen in this case.
So I want to ask you, just now you mentioned all the other lymph nodes are negative, right? So so what group of lymph nodes are you suspecting then?
The jugular chain, the anterior and the posterior jugular chain.
All right. Because I thought the way you write there is like all the lymph nodes, cervical lymph nodes are negative. Okay. All right. So that's your level 2, 3, and 4 lymph nodes, eh?
Yeah.
Okay. All right, sure.
Yeah.
Okay, so you still buy the history that probably it's a malignancy lah, more than the infective or benign. All right. Next.
I think so.
Mm-hmm.
Okay. Doctor, I just wanted to ask regarding, like, let's say the mass over there, should we straight away mention in the physical examination that, say, this is a lymph node, or we give the lymph node as the differential diagnosis?
Yeah, don't commit yet. Okay. Unless that you could feel that it's all over your cervical lymph nodes, that's not only at one point, then yes. Okay. All right. So I don't know, you mentioned earlier was multiple masses. So are they, multiple masses in a big lump, or is it separate masses that you could feel? Separate lumps, I would say, not masses, separate lumps, not connected to each other. Or are they those very matted kind of lymph nodes, very hard? Then if you think that's a lymph node, then you can actually commit. Okay, because it cannot be explained by any other structures. Because when you say multiple masses, I still have in mind that, could it be a multinodular goiter, upon inspection. Only when you say, oh, it does not move with degradation, then I put MNG aside, really, right? So when you explain, probably you will explain more clearly whether these multiple masses not matted together, several separate masses, with the largest one at the lateral part of the left neck, measuring 2 centimeters. Okay. Okay. What have you prepared?
This is just something I extracted from Browse. They mentioned this when you see whether the mass is single or multiple. If there's multiple mass, most likely it's going to be a lymph node. If it's single, then look at whether it's anterior or posterior. Then see whether it moves or doesn't move with swallowing, and the differential diagnosis that they give in Browse, just to share. Okay, and
we discussed, right? Okay.
yeah.
All right.
Okay, so moving on to the investigation. So divided the investigation into for diagnostic purpose and for assessment pre-op purposes. For diagnostic purposes, the blood investigation I would like to do is a full blood count to look for infection, liver function test to look for probable liver metastasis that can cause deranged liver function, and also albumin level that might be a surrogate marker for nutrition status in surgical patients. Renal profile also look at whether there's any electrolytes imbalance, and thyroid function test. Imaging wise, I like to do a chest X-ray to rule out possibly a lung cancer or a TB in the lungs that can cause lymphadenopathy, an ultrasound of the neck, and also a contrasted CT head and neck to assess the nature of the mass. Other investigations would include a FNAC to confirm the diagnosis, and flexible nasopharyngeal laryngoscopy to assess whether there's any nasopharyngeal carcinoma or laryngeal cancers that is in the head and neck. For pre-op assessment purposes, I also divide the investigation into blood investigation, imaging investigation, and others. The bloods will include renal profiles and electrolytes, a thyroid function test, the HbA1c, the coagulation profile, and group screen cross-match. Group screen and hold in view of this patient is high risk for bleeding. Imaging wise, like to do a chest X-ray to assess the to look for failure, and also echocardiography in view of the OSA. Other investigation would include nasopharyngeal laryngoscope to assess the vocal cord function. Yeah.
Okay, so there are a few more things that you have to further have in mind. Okay, so the other thing is that are you sure that this is not something to do with malignancy? If thyroid malignancy is in question, where would be the usual metastatic be? You will go to the
Papillary thyroid would be the lymph node.
okay, hematogenous, right? So it goes usually to the bone, the
Bone and
lungs.
lung.
Later on you get elsewhere like brain, liver, other organs, right? So when you go to bone, then you are worried that the calcium is the issue, right? The other reason why the calcium is important as well is you have not actually ruled out parathyroid yet, okay? Right? Parathyroid glands, adenoma, most of the time parathyroid cancer you rarely see lah, okay? 1% only, so very rare, okay? But you still have to keep that one in mind. And the easier thing to actually check the heart will be ECG, right? Your pre-op. I think you didn't record it down. You put an echo straight. I think ECG will actually help as well. But echo in this patient post IHT definitely is important. Okay. All right. So I think the rest I think you have covered. The ultrasound that will be your gold standard. All right. So are you going to share the ultrasound or we are supposed to discuss now?
I have actually this patient, they do a contrasted CT postnasal cyst rather than an ultrasound. Like I couldn't find any ultrasound report lah. Actually, doctor, I wanted to ask, when do we do an ultrasound versus a CT scan in a neck mass like this?
First of all, if the gold standard for your level, you still need to do ultrasound, okay? So you want to look at the structures. There are two things. Number one, you can look at the mass, where it rises from. The other thing is that whether that mass actually encroaches or already invaded the surrounding structure. But that one saying that, maybe CT is actually a better modality lah. Okay, the reason we do the ultrasound also is to look at the features of the lymph nodes. All right, as an example, in a thyroid with the lymph nodes, you want to see whether the lymph nodes is actually suspicious or not. So without that, you can't actually determine whether the lymph nodes are suspicion when you do just a CT scan. But in this sense, I think probably most likely they didn't do because they are quite committed that it's a lymph node. And then you won't get extra information by doing just an ultrasound. Okay, the ultrasound probably will just let you know that there are multiple lymph nodes in the level 3, level 2 of the left side of the jugular vein. So it doesn't give you any information, right? Unless that you're thinking of other example, other differentials, like what we discussed earlier. Okay, so that's why in this case, the CT scan became more important than the ultrasound. Okay, and the problem in this patient going for a CT is that patient is going to go through another episode of lying down, okay, for the CT scan. Ultrasound, you can actually sit up and do, right? You can prop up the patient a bit, but with the CT scan, you need the patient to lie down. So you have to be careful about the airway and the patient's breathing during that CT scan.
Okay. Doctor, another question is in a neck mass or in any masses, when do you decide to do FNAC versus a true cut or core needle biopsy or versus a vacuum assisted biopsy?
We don't do vacuum assisted for neck mass. Okay, definitely no. Core biopsy, if let's say that rarely we do for neck masses, knowing that all the structures are very nearby all your major vessels. Okay, so we actually would actually keep on doing FNA only for neck masses. So even for lymph nodes, you just need to actually find out what kind of is it malignant or not, right? But obviously, if let's say you need more information from the lymph node, sometimes what they can do is to do an open biopsy instead of a core needle biopsy, because that's a safer way to actually extract the whole lymph nodes, all right? Especially when you need to send it for TB. When you do all this core biopsy or even FNA, sometimes you create the fistula tract, you know. So it's going to be a non-healing discharging sinus after that, or fistula already after that. So sometimes if you need the diagnosis, you probably need to excise, go for surgical excision, take out the lymph node, okay? Or else you do FNA, okay? So we don't really do core biopsy for neck masses. Not to say even vacuum is really out of question, okay? That one is breast. Breast, no problem. You know, breast is just a fatty tissue. So you can, you know, vacuum out, not the neck.
Okay. Dr. just had mentioned TB. Can FNA samples be sent for TB investigation?
Difficult. That's the reason why if you have a TB in mind, then you have to work up your Mantoux test, your ESR, everything. But if you want the lymph nodes as a diagnosis, it's better to do an open biopsy.
Okay.
So you see many medical, they still send back to the surgeon to just help them with the diagnosis, right?
Yeah. Okay.
Okay.
So show some results for this patient. The renal profile is okay, liver function is okay, electrolytes is grossly normal pre-op lah. Blood count was normal, HB was 14, it's fine, no features suggestive of infections. Thyroid patient is euthyroid biochemically. This is the CT post-nasal space. This patient did the CT outside, and it shows that there's a left mixed solid cystic cervical lymphadenopathy with calcification at level 2, 3, 4, and 5 of the lymph nodes. Okay.
So can you see normal thyroid? Let us see the report in detail. Left cervical lymph node. Okay. And then right side is good. Thyroid gland. Okay, with the focal calcified nodule on the left side, cystic nodule on the right side. So in that sense, it's better actually to add on ultrasound of the thyroid later on, right? You see whether it can be still the thyroid cancer spreading to the lymph nodes, you know, at this point of time when we don't know yet. Yeah, okay. Better, why do you need the ultrasound? What can the ultrasound be more superior than the CT scan in the thyroid? Because you can classify based on the
TREDS classification.
That's right. Okay, so a TREDS of 1.5, we don't know whether this is TREDS 4 or 5. Probably need a FNA of that nodule already. The other side is 1.8, cystic nodule. Okay, even though cystic is less suspicion, okay, but then the other one, the calcified nodule is 1.5. So it's best to do ultrasound of the thyroid to add on for this case. Okay.
Okay. Unfortunately, we don't have a thyroid. The ultrasound for this patient. The chest X-ray grossly normal. There's no tracheal compression. And there's no cardiomegaly, no pleural effusion as well. In this patient, they actually did a true cut biopsy of the left cervical lymph node, and it shows the features of metastatic papillary.
Is it huge? Oh, so it's a papillary thyroid.
Yeah.
Okay. Okay, so it must be quite huge for them to be safely doing a true cut biopsy lah. Okay.
About 2 by 2.
Okay, yeah. If it's a very small and shorty lymph nodes like that, it's a bit dangerous to do. And maybe the location is far away from your carotid. So yeah, you can, but generally it's quite dangerous to do, especially on freehand biopsy. You want to do can, but you do it on the ultrasound guidance. Okay, so it's a papillary thyroid.
Yeah. And the nasopharyngeal laryngoscope is normal lah. They actually did a CT whole body, they say for staging purposes. So I actually wanted to ask, do we do CT staging for all thyroid cancer patients?
Yes, you can, right? You still need to do a staging scan, all right? Either you do like a PET scan or a CT TAP, that's fine, but you have to include the neck if you want to do the CT scan, all right? Whether or not you do an MRI, that's the other question. Whether you want to look at the anatomical structures, how much is the extent of that the mass, then you can add on the MRI, Okay, but for staging purpose, CT-TAP and neck lah. Okay, this one I would actually, for me, I would actually still retrospectively go back and do the thyroid ultrasound. Okay, so it can give you a better TRAT score to see which is the one that actually leads to the cancer. Which part of it is actually the papillary thyroid, right? Okay, but in this case, no matter what, you will know that if patient is operable, you still take out the whole thyroid, right? Doesn't matter right or the left, you still take it out lah. Okay, right? But it's just that we are investigating it slightly backwards, right? A bit more like retrospective kind of investigation. You take the biopsy of the lymph nodes first before we actually check the surrounding place that may actually spread to that lymph nodes, right? Okay, so what did the CT neck says? The thyroid gland? No,
Dr. you mean just now?
No, the report here. So there's a dense cause calcification. So that calcification also probably one of the telltale sign also that you look from the, from the suspicious ultrasound scans, right? 1.8 centimeter. Okay, and then speculated calcification some more in both lobes. So this is it. Okay. All right. Okay. So does it have any spread? No distant metastasis.
No distant mets yet.
Okay, right.
Doctor, also I wanted to ask if, let's say, this is a case of no lymph nodes, there's no lymph node metastasis, it's only solitary thyroid nodule. Do we still stage them with the CT or any other imaging modalities? How do we stage them?
Okay, the reason why you get a CT in that kind of patient is different for what you did for this patient. All right, in this patient, it's already a cancer. So the reason why you do the CT is for staging of the cancer. We want to look for distant metastasis and for locally advanced or local infiltration of the disease. But if you have any STN, solitary thyroid nodule, okay, if it's a huge one, the reason you get a CT neck is to look at the extent of the mass, right, before you go in for a surgery. And also for any possibility of any lymph nodes surrounding there that may need a proper central or lateral neck dissection. Okay, if it's a cancer. But if it's a benign, it's a huge one, MNG, sometimes you still do the CT, but the reason is not because for staging. It's just because you want to look at the extent. So understand the difference in why we order CT in even benign cases. Okay.
So the purpose is different, but
different. Yes. So you don't need CT scan for all thyroid nodules. Okay. You don't even need for very obvious multinodular goiter with no retrosternal extension, no symptoms, no compressive symptoms. So you don't. It's not a must to get a CT also.
Okay.
Okay.
Okay, and so these are the pre-op investigations results are generally normal. EF is normal. Okay, just wanted to pause here a bit and discuss a little bit about the approach to a thyroid nodule. We have covered a little bit, so we just briefly go through lah. So this is one of the approach that is in browse. And then in workup of suspicious thyroid nodules, we mentioned about this TRATs, and doctor did mention this. And for FNA, the classification is the Bethesda classification. Doctor, do you have any comments on all these like classification?
I think it's good for you all to know at which period of time or what classification will require intervention. Okay, so you see the TRAT scoring. If you have any TRATs 3 with a big lump, right, more than 2.5, then you indicate FNA already. But nowadays they have moved towards not doing too many FNA too early, all right, unless it's TRATs 5 with all the suspicious features, because the rate of papillary thyroid carcinoma to grow and the prognosis is all still very good. So there's no harm in just following up with a close surveillance ultrasound. Okay, so that's why they've come up with all these TRAT scoring. It's like BRATs when you need to take a biopsy, when you don't have to, or else we go crazily and all nodules tend to biopsy them, right? So that is a guideline for us. So it's also a guideline for you all to know whether this patient needs intervention and how malignant is, what is the risk of malignancy. okay, in this group. So next, you do FNA, definitely you will go by the Bethesda classification. So Bethesda, the third one, 1, 2, 3, 4, 5, 6, right? Okay.
Yeah.
So the third one is the one that is very a gray area lah. Okay. So when you have a AUS or FLUS or FLUS, it still has a higher risk of malignancy, but whether or not it's really significant, you won't be able to know. All right. So either you observe the patient based on how suspicious it is in your TRATs, or you just offer a lobectomy lah. Okay. All right. But if you have 4, 5, 6, definitely you need a surgical intervention. Okay. So number 4, the issue with follicular is very special. Follicular from the FNA, you cannot tell whether it's a benign or malignancy. It's always just a neoplasm. All right. Neoplasm means it's just a growth. So it can be a benign growth or malignant growth. So you need to go in for a surgical excision. So whether you want to do a lobectomy, means a hemithyroidectomy, or a total thyroidectomy, it depends on what is happening to the contralateral lobe lah. Okay. So if you have a case of a multinodular goiter, and then one of it gets bigger and then more suspicious, so you biopsy that one, comes out as a Bethesda 4. So you know you want to go in, but the other side is all abnormal as well. It's all multiple nodules as well. So patient has been, having that for many years already. So you know that it's going to increase in size. So when you want to go in, sometimes you will just offer total thyroidectomy lah. Okay. Even now they say they leave a little bit for like a near total thyroidectomy, but definitely not subtotal thyroidectomy. Okay. Then they mentioned that near total thyroidectomy, right?
Yeah.
Okay. Now my question to all of you: what's the difference near total versus subtotal? Okay. So near subtotal nowadays, we don't use it anymore. Okay. So in years, long time ago, they tend to keep a few grams, about 15 grams a day, of the thyroid tissue, so that it preserves the thyroid function for a patient. Okay, but it is not safe at all if you want to do for a thyroid cancer surgery. So if near total thyroid means you just keep the posterior capsule of the other side of the thyroid gland. So let's say this patient has a left thyroid cancer, the right one is not affected. You probably want to leave the posterior capsule behind and then remove the rest of the thyroid out lah. So it's like almost the whole thyroid is out already. Okay, but sometimes it may still you may need some thyroid replacement. So even though near total lah, right?
Doctor, what is the
Okay.
reason they leave behind the posterior capsule?
Yeah, for the reason the same lah as why you want to keep a bit of remnant tissue for the thyroid hormones okay, but sometimes it's too minimal to actually enough lah to without, I mean, it won't be enough if you don't give any additional thyroxine supplement okay. You just hope that by keeping a bit of the tissue there, it can still provide the thyroid hormones okay. So now back to whether it's important to know. Yes, it's important to know both your TRATs and your Bethesda. General, grouping will do. Okay. In detail, if you can memorize what are the suspicious features in the ultrasound, I don't think so you can memorize the scoring, but at least you know that, taller and wider is definitely worse than wider than taller, things like that lah. Okay. All right. Presence of, microcalcifications or extra thyroidal tissue extension, that one is bad lah. Okay. Things like that. I think that would be sufficient for you.
Okay. Doctor, just wanted to ask one thing. Just now I mentioned about in gray area, sometimes you do a hemithyroidectomy and to assess. Let's say it's a solitary thyroid nodule, quite small in size. You do a hemi, it comes out to be, let's say, a PTC or even a FTC. Do you do a completion, so-called completion hemi, or do you just leave it alone?
This one, you have to go back to your American Thyroid Association guidelines for differentiated thyroid carcinoma. I think nowadays they have certain risk factors, okay, for thyroid cancers, all these papillary especially, and also follicular. So they differentiate into a low risk, intermediate risk, and a high risk. For example, low risk are those like less than 1 centimeter with no extrathyroidal extension, no lymph node seen. Those with a more favorable histology subtype, things like that. You can go through that list, as compared to the high risk, like more than 4 centimeter, with without all these lymph nodes involvement, that kind, you know that, okay, that group of high risk is better to do thyroid completion total thyroidectomy. Okay, if let's say that the margins are all clear in a small tumor, low risk one, you can just leave it alone. Okay, and then just monitor your subsequent thyroglobulins and your TSH levels. Okay, all right. So go back to your ATA classifications. Usually small one, you don't have to take it out already.
Okay.
Okay.
Okay. And this one is just taken from the book, so I think we all can read by ourselves. And then the staging for thyroid cancer, something special is less than 55 years old. M1 is only stage 2 for papillary thyroid cancer.
Because the prognosis for papillary thyroid cancer in 10 years, is it good?
It's very
It's
good.
very good, right? It's almost 98, 99%, right? So they look at people who are older, the chances of the prognosis a bit worse. So that's why even the staging become worse than the younger ones. Okay, but even though this patient is young, he came in a bit late, right? With the lymph nodes all involved already. So what do you think would be the best for him? So this differentiated thyroid carcinoma means all the papillary and the follicular works very well with chemo? No, right?
Generally, no.
Okay, generally no lah. Okay, so we don't like the other cancers. We probably think that lymph node is positive, then you give some chemotherapy, but not for this case. All right. So surgical resection is still okay, followed by probably some radiotherapy. Do you have the management? Yep.
Yeah. So
What do you think is metastatic?
Sorry?
Oh, because the lymph nodes are okay. All right.
Yeah, because of the lymph node. So the final diagnosis was a metastatic papillary thyroid carcinoma. The management divide into a non-operative approach and operative approach. Non-operative, this patient needs a multidisciplinary care in view of very high risk, and then we need to optimize the medical condition of these patients first. The definitive approach, the definitive treatment is actually operative total thyroidectomy with neck dissection. I have a few questions regarding like this management. Doctor, what is the role of RAI in this kind of patients?
So this one you're talking about post-surgery or RAI before? Because normally before there's no point you give lah, all right? Because this is a thyroid carcinoma. The first thing you do surgical resection, but later on you want to ablate the thyroidal function, right? So that's the reason why you want to ablate off the remnant thyroid tissue lah. Because you want to actually suppress the thyroid function as low as possible, okay? To a certain level of your TSH, okay? That one you need to go through yourself because you do need to suppress in high-risk patient to a TSH of very, very low. You need to actually achieve like less than 0.5 or something like that, a very, very low level. So if let's say that increasing in your TSH, it means that the cancer probably has recurred. So your RAI actually kills off all these remnant tissues to achieve what we think as a suppressor. Okay, chemo, unless it's distant metastasis, you can't operate on the patient. There's some role for the chemotherapy. Okay, but radiotherapy, yes, after the surgery, you probably want to give for those high risk patient a radiotherapy to the neck. Okay, right?
Doctor, in what patient do we give an adjuvant RAI? In what kind of patient?
Patients who has thyroid carcinoma, okay, which has higher risk disease based on your ATA, okay. So you to really clear off all that, okay, and also the doses for the radioablative iodine is different for those who are at intermediate risk versus the high risk one. For example, the low risk probably they give about 30 mercury or something like that, 30. But I can go up to about 200 for the high risk one. Okay, especially those that still has a remnant of tissue, thyroid tissue noted on your whole body scan or your radioiodine scan. Then either you go back in to take that or you suppress it with the RAI. That means you give a 131 iodine suppressive dose, okay, to ablate all the tissues.
Okay.
So all those adjuvant therapy are actually given to reduce the risk of recurrence for the patient. Okay, understand? Okay,
And
so yes, you asked. You asked.
you want to So I wanted to ask regarding the medical condition, how do we manage them? Because this patient just had a PCI 3 months ago. Is it optimum to operate now? What is the time frame of from last angio to the optimum time where you can operate safely? And this patient needs to be on DAPT. When do you stop the DAPT before the surgery?
Like you mentioned, I think all this need MDT discussion. All right. So what is the risk of another episode of IHT if you stop the DAPT? So is it an urgent thing or not? Number one. Number two, is it an urgent thing for this thyroid to come out? Okay. Since it's malignant, you cannot wait for another 3 more months. Okay. To safely say that at least 6 months post PCI, it's safer to operate the patient then. Right? But if it's an elective, no problem, you can wait until 6 months later, minimum. But this is a cancer. So you have to balance the risk versus the benefit of this patient really. You can't wait further for the malignancy. If you wait a bit longer, it will start to mets elsewhere and you can't even operate on the patient. So then you have to talk to the to the cardiologist. Whether is it possible to off the dual before the surgery? And what is the risk to the heart if you completely off both? Okay. And then you have to talk to your own team. I mean, if you're the surgeon, then you have to decide whether you're happy to operate with one antiplatelet on board, for example, just the cardiprine, or not. Okay. That means you have to be very careful in your hemostasis during the surgery. Or you think that this is all going to be method, it's a cancer, it's not going to be simple. Everything's going to be probably stuck down to your even vessels around. So the risk is too high, then we have to tell the cardiologist, sorry, we probably need to off it before we can operate. So at the same time, you definitely need the anesthesia to stand by in case the risk of the patient of getting MI during the surgery is probably high, or even stroke after the general anesthesia. So all this you have to manage it like as a team lah, and also to tell the patient that this is not a simple surgery, it's going to be high risk procedure. Okay, so now whether or not we do radical neck dissection, this case definitely we have to do lah because the lymph nodes is positive. So generally, if we go in for the surgery for a known case of differential DTC lah, I just call it as DTC, differentiated thyroid carcinoma, you don't need a neck dissection. You don't need a prophylactic neck dissection. Some books say that those high risk people probably want to offer a prophylactic neck dissection. But we can offer prophylactic, but we don't do berry picking, like we only pick a few lymph nodes and send it off. Okay, we don't do that. Either you do it, the whole central neck means you're level 6, or you don't do it at all. Or if let's say you see some lymph nodes positive at the lateral, then you have to extend to the lateral neck dissection as well. Okay, so it's not for all lah. Low risk one only.
Okay.
Anything else?
Doctor, also I wanted to ask, we all learned that before thyroidectomy, we need to make sure that patient is clinically and biochemically euthyroid, or else the risk of thyroid storm is high. Let's say it's a cancer patient and the patient is thyrotoxic. Can we wait to like manage that medically first before you go in and
So the question I'm going to throw you back is that how frequent have you seen the carcinoma with hyperthyroid?
It's not likely, but let's say it's a toxic MNG, thyroid cancer or toxic MNG. I'm not sure whether is it common, but we know like most cancers
Okay.
are cold nodules, but let's say
Yes. So you're talking about a very rare condition where you have toxic MNG, and then one of it became malignant. Now one of the nodules become malignant. Okay, if you really have that situation, then you have to quickly bring down the hyperthyroid status, right? Okay, so then you have to talk to your endocrine medical colleagues to probably give glucose, iodine, or PTU to bring down the thyroid hormone as soon as possible, and then you proceed with your surgery. Okay, especially when you deal with someone who is having obstructive symptoms. We do sometimes patient who has a huge MNG, all right? So that kind of patient, let's not talk about cancer. Let's talk about probably like compressive symptoms. Patient who has many years of MNG, right? And also probably has hyperthyroidism also. And then suddenly don't want to do anything, and then suddenly just obstruct. So you need to do emergency thyroidectomy to relieve the obstruction. Patient cannot breathe anymore already. Can't even intubate the patient. So sometimes you need to quickly take the isthmus down, put in a trachea tube, then remove the rest of the thyroid. So in that sense, no choice. You have to give glucose or even PTU lah. But have to be careful of the heart lah. Okay.
Okay. Okay. So this is the thyroid. Doctor, is there anything we should know about this process of thyroidectomy?
Maybe not the details step by step. Okay, but I think the important thing is identify the structures. The important structures related to the thyroidectomy. Number one, vessels, the nerves. Okay, and also your parathyroid glands. Okay, so all this you need to mention. You need to know. So the supply to the thyroid gland, need to know what are the important nerves nearby, recurrent laryngeal, your external branch of the superior laryngeal, okay, and then identification of your parathyroid gland. Where is the location of the parathyroid gland? Superior one is usually fixed. The inferior one can go down, even down to your mediastinum, right? Okay, so at least preserve that, and always mention that you would like to offer intraoperative nerve monitoring as well, okay, for the patients. Or anything else you want to know about this thyroidectomy procedure?
Do you also, I mean, in a cancer surgery, the parathyroid gland, is it also commonly preserved, identified and preserved?
Cancer
It's,
surgery,
yeah.
Probably a bit difficult, especially on the side where the cancer is involved. But if the cancer is not involving the whole thyroid, the other side you probably can still keep at least one parathyroid gland, right? Yeah. So you still need to identify both sides. But the cancer side, if it's difficult, then no choice. You have to sacrifice it.
Okay.
Okay. All right. Complication. All right.
Yeah, just go through a bit about complications of thyroidectomy, immediate and I divide it into immediate and delayed lah. Immediate complication can be hemorrhage or hematoma in the neck, nerve injury, thyroid insufficiency, parathyroid insufficiency, thyroid storm. Delayed can be wound infection or keloid scar. Doctor, I just wanted to ask, how do you differentiate, if patient post-op thyroidectomy, a few hours suddenly develop shortness of breath and probably obstructive symptoms, how do we differentiate whether it's due to bilateral nerve injury that caused the vocal cord to be adducted, or is it a vocal cord edema due to the intubation, or is it due to a neck hematoma? How do we differentiate that by the bedside?
Okay, number one, hematoma is very obvious. Okay, you can see it yourself. It's enlarging, right? Because the space is so small, and then you put in one single small tube out, the drain is definitely going to block. All right. So once it's blocked, it's going to increase in front. There's nowhere to go already. It's all limited by all your neck spaces, right? So you know there's increasing neck mass. Definitely, you know it's hematoma. Okay. Now the second scenario is when you don't know whether it's vocal cord injury because of the intubation or bilateral recurrent laryngeal. Well, when you have a vocal cord edema, usually it's temporary and rarely that they hit both sides. Okay, but if let's say that patient has problem in breathing, whatever you do, okay, it's only one. You need to secure the airway, correct? Not it doesn't matter what is the cause. The cause can be investigated later. But the airway needs to be secured first, your ABCDE. So what do? You will still put in intubate the patient, or you cannot intubate the patient, you put in a trachea tube. Correct or not? So you have to bring the patient for trachea tube. You can do it bedside percutaneous, or you go in and put in a trachea tube. Okay, whether it's going to be permanent because you injure both sides, the recurrent laryngeal, is for you to investigate later. Okay, emergency means emergency. The difference you need to know is the hematoma. Because hematoma, you need to, at the bedside, you need to straight away open up, let the hematoma come out. You cannot even wait until, we call the OT, OT now running another trauma case. Okay, after 1 hour, patient will die. Okay, right, immediate.
So doctor, for if it is a hematoma, we open up first or intubate and secure the airway first?
Open up first, all right? Just clean the area. the wound must be still quite fresh, right? Okay, so you can just open up first. If your worried patient is in pain, just give a quick LA lah, and then you still need to just cut open the suture that you just sutured. Release that out first, pack the wound, go to OT, properly intubate, wash, put it in the new drain. But you cannot, what I mean is you cannot just keep the patient with the enlarging mass in stridor and then you wait for the OT to call. No. Okay. All right. From your delayed complication, maybe you should, wait, let me see. Okay, maybe you mentioned under parathyroid insufficiency and thyroid. Okay, so in the end, you need to see whether patient needs a long-term thyroid supplement or any calcium calcitriol supplement as well. Huh? Okay, so your nerve injury, sometimes it's just transient. So we can observe up to probably 8 weeks or so. If it goes beyond that, sometimes it may be permanent. Some people even have it up to like, even the calcium can be transient only, the hypocalcemia. So if it's a permanent, even up to 1 year, if it comes back again, once you stop the calcium, right, and then the calcium starts to drop, then you know that you are probably dealing with a permanent hypocalcemia rather than a transient.
Okay. So any other complications that are common that I might have missed in this list?
Unless you talk about tracheomalacia, tracheal injury, rarely happen, but sometimes very prolonged chronic obstruction, you may find that the rings over the trachea became soft, So then when you remove that neck mass, it becomes like collapse like that. So trachea is supposed to have trachea rings which are stiff, right? So this is like weak. So the patient tends to have immediate like airway compromise because of the stridor. So that one patient needs to be on permanent tracheostomy.
Oh, okay.
Okay. What else in complications? I think, yep, probably that. Okay.
Okay, so this is just the operative record lah.
One more complication, but very rare is the caul leak. Caul, especially when you do the lymph node dissection, and especially when you injure the thoracic duct. But rarely unless you go and dig until very far off, then you find your thyroglossal, what you call it, duct, and then you start to have a leak of the caul, means a milky discharge. But you rarely see that. Okay.
This patient did have an intra-op thoracic duct injury that was repaired, and yeah.
Thoracic duct injury. Oh, okay.
Yeah.
Okay.
And post-op, they actually noted tracheomalacia. They scoped the patient post-op and noted tracheomalacia. And this patient was admitted to ICU. He was hemodynamically stable throughout. They continued the levothyroxine, calcium supplement, and calcitriol, and also the DAPT. They extubated in OT after a leak test on post-op day 2. They removed the drain right side on day 4, left side on day 6. And what happened next was this was the calcium post-op day 2. So actually the corrected calcium is low. In view of serum albumin is low, so they do a corrected calcium. It is low. Post-op day 7 in the morning, the patient went to the washroom in the morning and then suddenly complained of sudden onset worsening neck swelling and pain around the surgical wound with mild shortness of breath. And the ward team noted the neck to be tense bilaterally and anteriorly, but no obstruction. They opened up the suture and then aspirated minimal blood. They did a minimal exploration by the bedside and then compressed over the wound, and then the patient was hemodynamically stable throughout. They applied face mask and high flow mask, and then they sent them to OT for elective intubation and exploration of the neck. He was hemodynamically stable, but after induction, the patient actually has difficult intubation and desaturated in the OT, and that was the intra-op evacuation findings. So just now actually doctor mentioned about how do you manage? Actually, I wanted to ask.
Yeah, what you want to ask?
No, actually, that was one of the things I wanted to bring up as the HO in the ward. Let's say we have this patient, what should we do before our MO came?
You can become a hero. Then your HO in between you got ER already because you're a hero already. So honestly, I mean, if you know what to do, before you can just inform your MO straight away. You prepare all the set ready, and then just open it up only. So that's what we discussed earlier, lah. You can't wait until you go to OT. You can go to OT earlier, but you see, I mean later, sorry. The estimated blood loss in that small space is 1,200. You know, how can you get all this blood inside without releasing it, right? Right. Patient will collapse, okay, and yeah, interesting case, right?
And doctor, just wanted to close up this case. So on follow-up for this patient and thyroid cancer, metastatic thyroid cancer setting, what should we monitor for follow-up and how frequent do we monitor them?
So normally we will still need like at least 6 months of ultrasound for follow-up lah. So the other thing you monitor is of course your thyroid function. Make sure that patient doesn't go into hypothyroid. And then for cancer wise, you have to monitor the what you call it, TSH level lah. Whether or not you do a thyroglobulin is another question. Some I think some practice they don't really do that anymore, but for high risk, probably they still do a thyroglobulin, right? So you do a TSH to achieve your suppressive level, okay? So that differs based on the risk. For this one, definitely, I think you need to target less than 0.5, I think, for the TSH, all right? So besides that, you will need the 131 iodine scan for this patient to look for the remnant iodine to suppress the thyroid function as much as possible. So before you do the iodine RAI, you need to advise the patient to avoid all the iodine content food, and then you need to stop the thyroxine for about, I think about, they have a regime, like, I can't really remember, but 2 to 4 weeks, you know, prior to your scan, so that a TSH can go up, the non-stimulated type. Or you can give a recombinant type of TSH, okay, to just promote the, see how much your TSH goes up. So that what we do is when the TSH goes up, it's easy for the scan to pick up. All right. So when you suppress it with the thyroxine, then you don't get the TSH, then you don't see the stimulating effect in the scan. So you can't see whether there's any remnant tissue there or not from the RAI that you do. So that is part of the treatment as well as for diagnosis. Okay, so you can use the 131I for both diagnostic and also for treatment. So follow-up, surveillance, as well as your treatment earlier that we mentioned, right, to ablate the tissue. Okay, there's also that 123 iodine, but I think they rarely use it because of the cost issue. Okay, but they also same thing for diagnostic for surveillance purpose. Like you can use the 123I as well. Okay, so besides that, I think there are that 4 things that you need to follow up the patient with, all your blood tests as well as your ultrasound.
Okay. So that's all actually for the first case. Does doctor have any? The second one is a bit shorter case lah. Does doctor have anything to like no? If anyone has any question, you can type in the chat box. We can address it later. Now I'll pass on to Z for the second case.
Okay, hi Z.
Alright, so good morning everyone and good morning doctor. My name is Ko Zhi Yi. I'm a stage 3.1 medical student. Yeah, nice to meet all of you. Yeah, it's almost 10:30. Yeah, so sorry. So I will try to keep my part short and sweet lah. So Mr. MYP is a 79-year-old Malay male. And then next slide for his chief complaint. His chief complaint is a 4 months history of swelling over the center of the neck. And then let's move on to the HOPI. The patient was apparently well until 4 months ago when he first noticed the neck swelling when looking at the mirror. So he mentioned that they have always been swelling in the neck since his childhood, but for this, he was unsure of the age of when it first started, and the swelling was minimal and not noticeable. So the swelling was at the center of the neck, and the size at first was around the size of a 20-cent coin. However, the size gradually got bigger over the past 4 months. And then the swelling also moves with swallowing. That's what the patient noticed. And then 2 weeks ago, the swelling was accompanied with pus discharge. For the pus, the consistency is thick, and then the patient mentioned that there is a large volume of pus, so that the shirt was stained with pus as well. And then the pus was light red in color with streaks of blood, and it was relieved after the antibiotics. Otherwise, there was no redness, skin changes, and pain. So next slide, please. For the systemic review, there was no other ENT symptoms such as hoarseness of voice, dyspnea, and also dysphagia. There are no thyroid symptoms such as the mood swing, heat or cold intolerance, and then the urine or bowel output is normal. There were no diarrhea or constipation. There were no palpitations, no constitutional symptoms such as the loss of weight and appetite. There was no TB symptoms as well, such as the fever, cough, or night sweat. And then the patient also mentioned there was no sick contact. So anything doctor wants to comment before we move on to the past medical?
I think this one almost the same like before, that case before. It's a long time of neck swelling, but this is way even before the adulthood, since childhood. All right. So you have to think of something which happens in the pediatric age group as well for this case. Okay. And this one moves with swallowing. So you still have moves up or what? Moves up, I assume. Moves up.
Yes.
Okay. All right. So you still have to think of thyroid in this case, right? So what
Sure.
else have you asked the patient?
Yeah, that's all the history. Wait, sorry, the past medical history. Yeah, for the past medical history, yeah.
So it sounds like he has some recent infection, right, for the past 2 weeks, because everything
Yes,
sounds like it passed and
the past discharge.
pain. Okay.
So for the past medical history, he was pre-diabetic, diagnosed around 2 years ago. He was on the sulfonylureas and was compliant. However, he has no follow-up and there were no complications. The renal function is normal as well. For the hypertension, he was diagnosed around 3 years ago and he was on amlodipine, valsartan, and diltiazem, and he was also compliant to all the medications. He has no follow-up and self-monitoring as well, and he had never had any past medical history than both of these before. Yeah. The next slide, please. For the other relevant history, for family history, he has no family history of diabetes or hypertension, no family history of thyroid diseases, and also no family history of malignancies. And then for social history, he was a smoker of 36 packed years. Sorry, doctor, anything you want to comment?
No.
All right, sure. He started smoking when he was 18 years old and stopped after 25 years ago. No alcohol consumption, and then his occupation was a retired businessman, and he had no history of the radiation exposure. That's all for the history taking. Yeah. All right, so...
Okay. Yep, you can go ahead. I think we have discussed the same thing that you all need to have in mind, the benign versus the malignant. But it doesn't sound like maybe it's a malignant transformation later, but it doesn't look like a malignancy from history, right? Okay, all right. Infection is still in mind.
So for the physical examination.
Yep, go ahead, Ray.
For physical examination for the periphery, there was no excessive sweating, normal warmth that is equal on both sides of the hands, palmar erythema or palmar pallor. There was no thyroid acropathy or onycholysis as well. For the pulse rate, it is 64 BPM, good volume and regular rhythm. And there were no fine tremors as well, so everything looks normal. And then for the eye examination, there was no chenosis, no proptosis or thyroid stare, no ophthalmoplegia and deep lag. And then for the reflexes, it is normal. There was no proximal myopathy as well. The only thing we noticed is that there is pitting edema up to the knee upon the leg examination. For the neck examination, however, there was a midline neck mass measuring around 4 × 3 cm. It was firm in consistency, has a lobulated surface. and the margin was well defined. The mass was mobile and it was attached to the skin. However, there were no skin color or temperature changes and no draining sinuses or punctum. For the mobile part, the mass actually moves on swallowing and tongue protrusion, and there will be a video later explaining this, and we can get above and below the mass. However, there was no distended neck vein, no retrosternal extension, no trachea deviation, no thyroid bruit, and no enlarged lymph nodes. So next slide, please. The next slide is a video showing the movement of the neck mass. Yeah. Yeah, it moves above with swallowing and also when protruding the tongue. All right, next slide. All right. Yeah.
Very straightforward, right? Listen.
Yes. It's quite a straightforward case.
How did you manage to get this case? Very lucky, yeah.
Yeah, we found it in the surgery ward.
Recently, this patient. Is it recent?
Yeah, quite recent actually.
Oh, I'm surprised that my 3.3 group didn't bring this case, such a good case. Okay, so I think this one, it's thyroglossal unless proven otherwise, right? Okay, all right.
Yes.
But the other thing that you can include is probably your thyroid as well, okay? Because you still say that it moves up with deglutition, right? So whether it rises from your thyroid, maybe, okay? But the thyroid will not have movement with protrusion of the tongue. So that will rule out a thyroid mass eventually, all right? So is it a bronchial cyst? It's not so midline, all right, for your bronchial cyst. Okay, your what cystic hygroma is even worse. That is more posterior, right? So you are thinking of something more from the pediatric age group. So you won't put in unlikely to be those cancer like PTC or even your lymphoma. You probably will not give as a differential for a 79 years old who lives throughout his 7-8 decades of life with that mass. Okay, all right. Lymph nodes, well, if the infection causes another lymph nodes nearby, I will agree. But the mass itself, I don't think so. It's a lymph node. All right. Okay, so is it common to get infection in thyroglossal?
From what I searched, it is actually a common complication, and the pus is also a common complication.
That is the only reason that brings someone to the hospital some of the time. Because most of the time they think that they have lived through their life with this mass and it's not enlarging, so they rarely see the doctor. Okay, unless a very young patient who feels very uncomfortable with that lump, okay, then they'll probably come to the hospital even though it's not infected. Okay, all right. Any other questions you want to ask? Okay.
Can you skip to the investigation results, because all the lab investigation for this patient are actually quite normal for his age. For the thyroid function test, there is no abnormality seen as well. All right, so let's skip to the imaging investigation. Yeah, for ultrasound of the neck, these are the findings. There was a well-defined lobulated cystic lesion of the non-aggressive nature superior to the thyroid gland and is suggestive of thyroglossal. So just want to show everyone how the thyroglossal will look like in an ultrasound.
Which one? I don't think so. You're showing the right images because you can't move it, right?
Yeah, this is done outside, so there's only this particular film that is in the EMR. Yeah.
I think they're just showing you the thyroid glands instead of the thyroglossal itself, because it's so huge. It cannot be. It should look cystic. Cystic is very hypo or anechoic kind of feature, so you don't see that. And that two sides, that one likely are the vessels only. So you can't really see that because it's 4.9 centimeter. It's quite huge. So the same things you have to see lah. Number one, when you look at in a thyroglossal, number one, you have to make sure that the thyroid is there. Okay? Because if let's say that patient doesn't have a normal thyroid, your thyroid tissue is probably embedded inside that thyroglossal. So it's dangerous if you take out the thyroglossal cyst without checking for a normal thyroid first, because patient will go into hypothyroid status after your surgery. Okay, the other thing is, of course, to look at other features of malignancy. So in this case, it says that it's actually just located superior to the thyroid gland, is it? Whether is it stuck to the thyroid gland or not, it didn't mention.
No, they didn't mention in the report.
Because if it's very near and stuck to the thyroid, sometimes you may get what you find, move on swallowing as well. So maybe it's because it moves together with the thyroid gland as well as separately itself by the protrusion of the tongue. Okay, let's see then. You have a
The
CT.
CT, yes.
Okay, so it's quite a huge one there, but it's very, very benign looking, right? You have a capsule around there. Okay, but it's pressing against the part of the trachea already, right?
Yes, there is a midline shift.
Midline shift to the left side. So it's mainly on the right side. Okay. It's on the left, lah. It's on the left side. So your midline shift should be to the right, right? Are you sure you didn't copy it wrongly? Because you can see from the term, the one on our left is the right side of the patient. On our right is the left of the patient. So obviously the mass is towards the left side and is compressing on the left side, causing part of the trachea to be slightly compressed, but it's still patent. The shift should be towards the right, not
right
side. Yeah. Okay, anything else?
All right, the next slide is about the management of the patient.
Okay.
So for the management, usually they would do the elective surgical excision, which is the cyst trunk procedure to prevent the infection, which is a common complication. It includes the removal of the cyst, a portion of the hyoid bone, and also excision of tissue, comprising the path of descent for the foramen cecum. So the picture on the right is the patients after the thyroglossal cyst is after the surgical excision of the patient. Yeah.
Did you go in for the surgery? Because it's quite interesting surgery. You didn't go in.
We didn't go actually. Yeah.
Okay. Because for you to remove the whole thyroglossal cyst, you need to cut part of the thyroid bone out. So you have to actually use a bone cutter. If it's soft, then you can just cut it away using the scissor. But you need to actually take the whole cyst out without disrupting the cyst. Okay, the reason is we don't want it to spill out the cyst content. Even though you have very, very low risk of carcinoma, there's still a chance of carcinoma within that thyroglossal cyst. Okay, and if you can, you try to remove it in en bloc manner. Means that you even sometimes need to remove part of the strap muscle that encases that cyst, and then you go track. There'll be one track of that tissue up to our base of the tongue. But of course, in a normal thyroglossal cyst without cancer, you don't really need to, pull until the level of the base of the tongue. So as long as you can get as high as you can, then you can just cut it off and then remove it. Okay. Then if let's say it's a cancer, then you probably need to go in again to explore up to the foramen cecum. Not an easy one. Okay, so number one, infection. Yeah, you treat the infection first. Okay, right. Yes. So once the infection settle, you can do the cyst trunk as an elective. Okay.
So another thing to note is the incision and drainage procedures should be avoided unless there is the compromise of the aerodigestive tract. Yeah, because it will further complicate the surgical procedure.
Yeah, then you find it very difficult to delineate cyst wall also. So it's the same thing like when we do sebaceous cyst excision, so we try not to rupture the cyst, right? Because you have to completely remove the cyst wall to avoid recurrence. So this one also you want to take the whole cyst wall out. Okay, so try not to cut through it.
All right, I see. So next slide, please. Okay, for the discussion, it is actually a common case for the epidemiology. It is the second most common neck abnormality and is 7% of the population. For pathophysiology, the thyroid gland will originate from the foramen cecum and then descend caudally, forming the thyroglossal duct. So if the thyroglossal duct fail to obliterate, it will form the cyst or ectopic thyroid tissue even. For the clinical feature, The cyst will be present from birth and usually detected during early childhood, which is seen in this patient. And it will be a painless, firm, and midline neck mass that elevates with swallowing and tongue protrusion, which is also seen in this patient. Usually, it's located near the hyoid bone, and it may cause the compression symptoms such as the dysphagia or the neck pain, which the patient don't have, but it may cause. Okay, next slide, please. For the diagnostic, usually from examination, we can see that it is the thyroglossal cyst. Ultrasound of the neck can also evaluate the cyst and confirm the location. Contrast-enhanced CT is actually the preferred imaging modality, as the thyroglossal duct cyst can be demonstrated as the well-defined lesion with homogeneous fluid and the surrounding rim enhancement closer to the hyoid bone. And then TSH levels can also be used. And if an infection is suspected, the fine needle aspiration should be performed for the culture. Yeah. So for complications, infection of the cyst with abscess formation, which is seen in this patient, the infection 2 weeks ago. And then also it may form the sinus tract with persistent drainage. Sometimes the atopic thyroid tissue can also happen, and malignancy arising from the atopic thyroid tissue as well, like doctor mentioned just now. Yeah. So that is all for this case. Yeah, please.
Okay, right. An interesting one. Very straightforward, but when you get it in the exam, you probably will struggle a little bit. Unless it's very clear cut, it's a tongue protrusion. Okay. Some people are so afraid to commit it's a thyroglossal cyst. Okay, any questions from the rest of the audience?
Any questions from the floor? You can raise hand and unmute yourself and ask verbally, or you can type in the chat box as well.
Let me see the chat box. Okay. Seems like no question.
Yeah.
Too much to digest.
All right. So I just want to thank you so much, doctor, for this session. And then I hope everyone can learn a lot about neck masses from this session. Before we end, can everyone please turn on your cameras? Oh, wait, sorry. There was a question in the chat box.
Oh, okay.
So,
let me see. Maybe you can read it out first.
Yeah, sure.
Okay.
So the question is, doctor, may I know what is the correct term when the thyroid is not in the actual location?
Ectopic? Ectopic thyroid tissue, is it? You want to say? The thyroid not in the correct position, right? Ectopic.
Good evening, doctor. Yes, but we when that topic we heard from Dr. Cole was when the ectopic is termed when the thyroid is no longer inside the midline of the neck. However, sometimes the thyroid so we don't know. He mentioned that it's another term when it's still within the midline, but it's just not within the original location. So is there another term that you would know of? Because I was not able to find the actual term for this. When it's not in the actual place, but it's still within the midline. Yeah. Sorry, doctor.
You mean it's along the thyroglossal duct lah? Is that what he meant? Because
Yes.
your thyroid, when embryologically you don't actually stop anterior to your what do you call this thyroglossal fascia, I think. Then it can stop anywhere above that, even can be part of that thyroglossal cyst. But whether there's any separate term besides ectopic, I'm not so sure. Maybe I get back to you if I have the answer. Why you didn't ask Prof. Ko that day?
Because during that day, during the CRS, he mentioned he also couldn't quite recall at the time, and I also didn't want to put him on this. Yeah.
Okay.
Thank you very much.
I can just go back and check and see. Yeah. As far as I know, I think it's called as ectopic lah. But I think what he mentioned was probably correct also. I think what he would say is that sometimes the ectopic can go down into the mediastinum, even even at the upper part of the suprasternal region. But that region is out of where the embryological location of thyroid should be. So that one sounds like an ectopic lah, all right? Means it's not within that same embryological migration path. But within that, let me find out, see whether there's any other specific. Okay. All right.
Thank you very much, doctor.
Okay, thank you. You want to take photo, is it? Yep.
Yes. Is it
Okay.
all right if everyone turn on the camera so we can have a quick photo taking session before we end?
You have this every week or every month, is it?
No, actually not every week, yeah.
Ad hoc. Okay. Tomorrow I've got a talk also in Bangsa. Haven't actually prepared yet. Okay, right.
All right.
Sorry.
So I'll take a picture now. All right. 1, 2, 3. Another one. 1, 2, 3. All right.
Okay, thank you, Zee.
All right. Thank you so much, everyone, for joining, and thank you, Doctor, as well, for the very informative session. Yeah, I'm
Thank
sure
you very much,
everyone will
Doctor.
learn a lot from the session.
All right. Okay, see you, orang. Okay, bye-bye. Good night.
All right. See you, Doctor.
Thank you, Dr. Teoh.
Okay.
Thank you so
Dr.
much,
Teoh.
Doctor.
Thank you, Doctor.
Thank you very much, Dr. Teoh.
Thank you, Dr. Teoh.
Bye-bye.